All right. So to continue our talking about the most common cases in acute medicine, the urinary tract infection. Last time we had a discussion about AKI and about the guidelines in AKI and how to deal with it. Today we are talking about urinary tract infection. So the patient will present with symptoms to you, and you will decide, is it lower urinary tract infection or is it upper urinary tract infection like pyelonephritis or something like that? And is the patient in sepsis or not? Right. So this will be the first thing you need to know. So let's say the patient came to you, 82 years old patient, lady presented to you complaining of stingy wee and increasing frequency and smelly urine, and she was confused over the last 2 days. And the GP gave her some nitrofurantoin to treat urinary tract infection, but things getting bad and deteriorated, and she came to you to the hospital and has been seen by the A&E doctors. Okay, so again, we will go quickly through the administration sheets or the clerking sheet. So you'll find, as you can see in front of you on the screen, the name, the hospital number, date of birth. You can put the sticker there, and who is the consultant, and then put the age, put the present to complain, which will be here, dysuria and confusion, and then you can write all the details, and never forget to mention about the fertility score while you are taking the patient history. Take the patient history and put the post medical history, and of course these are the comorbidities. You can take the boxes there, and you can put the fertility score as well. All right. So you would after the fertility score would depend on a lot of stuff. First of all is the let me bring it up to you so you can see it with me on the screen. So the frailty score, can you see it now?
Yeah.
So the frailty score is something we decide where is the patient. Is the patient fit? Is he well enough? Is he managing well? Is he vulnerable? Is he mildly frail? Is he moderately frail? Is he severely frail? All right. Or he is terminally ill. Is something you are the medics, the paramedic, the SHO or the midridge need to decide while admitting the patient. And this depend on the comorbidities and what the patient can do. If the patient can do everything, so he is fit. If he is managing, if he this picture, he variably good on walking, but he is a little bit slow, but he can manage his own stuff, so he is vulnerable, and there's no problem about that. And if he's mildly frail, so he needs some help in the high order IADLs, like the finance, transportation, heavy housework, and medication. So we called it mild frail and moderate frail. So he needs lots of help, including bathing, and he had some carers at home. He needs someone to help him with dressing. So we call it moderately frail. And regarding the severely frail, he is completely dependent on for personal care. Is it understandable?
Yeah.
Yeah. All right. Okay. So let's go back to the clerking sheet. So it is something you should mention in the clerking sheet. What do you think the patient is? And this you will ask the patient where you are taking the social history from him or from the collaterals about with whom he live with, and is he in a social, is he in a care home, is he in his his own house, and if he is on house, how many carers he have, and who help him with everything, like chopping, washing, bathing. Do you get what I mean? Are you with me? Yeah.
Yeah. Yeah.
Good. Then you will take the drug history, what the patient take. The patient is on amlodipine for high blood pressure and is on ramipril as well for high blood pressure, and he is on lot of other stuff as well. I will just take this all and I will come back to you in a second.
Okay.
Right, sorry about that. So, to continue, the social history, as we mentioned, you will find about a lot of other stuff. If the patient has carers, of course, smoking and alcohol, and the carers and mobility aids, and all of this stuff. And then you will continue about the examinations, heart rate, the blood pressure, the weight, the oxygen saturation, and this really, really important about the heart rate and blood pressure, especially if we are considering dealing with infection. And then you will find the Glasgow Coma scale, how the patient is doing. Is he scoring 15 out of 15 or minusing some stuff? And what about the AMT? How is the mental status for this patient? Is he or she dementia? Is she had any cognitive impairment? And then the examination, as we mentioned before, if the patient jaundice, pallor, clubbing, cyanosis, it has any edema anywhere, and then go through the list for the GVP, listen to the heart sound and mention about it, see the peak flow, the breath sound, and then the PR. You will do this PR if the patient come in with upper gastro bleeding, upper GI bleeding. Upper GI bleeding, you should do the BR, and then have a look at the legs to rule out any edema or cellulitis, to
Mm.
rule out infection in the legs as well. You would examine him neurologically if you are suspecting a stroke or so, and then examine the chest as well and mention about it. And always do not accept patient without ECG and without chest X-ray. If the patient came to the hospital and he will be admitted under the medics, so you will need to have a look at the ECG and you will need to have a look at the chest X-ray. Right?
Yeah.
Is it clear? Is it clear till now? Yeah.
Yeah. Yeah.
Good. And then the diagnosis or the problem list, you will just put the diagnosis here. It is urinary tract infection and confusion. And if the patient is confused as well, you will need to do CT scan, CT head to rule out any problems. And then you will put the review. Because it is a urinary tract infection, before heading on, so now we will discuss about the management, how to management. What is the plan? What is the plan? What will you do with this patient? Before we are heading to the plan, we will need to read about sepsis 6 protocol. I think last time we did speak about sepsis 6 protocol, but again I will go through it.
Mm.
If a patient, every single patient come to A&E, or he is in the ward and had one of the criticals news, so he is scoring 5 or more, or 3 or more in one parameter, so we would consider infection, we would consider sepsis. And if you are considering sepsis, there is a protocol you should follow. Whatever the hospital, wherever you are in, there is a protocol you should follow. All right?
Yeah.
Okay. So if the patient has sepsis, it's mean that the patient is critically ill. He is critically ill. All right?
Mm.
Okay. So if the patient critically ill, so you would need to do three three main things. Make sure that his oxygen is okay, make sure that his blood pressure is okay, and make sure that the urine output is okay. Three main things, right?
Right.
Okay. So let's go through the sepsis protocol and see how to fill it. So this part, can you see it?
Yeah.
This part you will put the date and your name, and this is the patient details on the other side, and then find, is the patient scoring five or more one parameter? Yes, it will tick box. Okay. Is the source clear? Yes, it is urinary tract infection, or it is pneumonia, or it is cellulitis, or it is septic arthritis, or we don't know. The source is unclear yet, right? And is one red flag present? Can you read the red flag?
Yeah, I see.
Read it loudly.
Respond only to voice or pain are responsive, or systolic blood pressure less than 90, uh, or drop less than 40 from normal, heart
Mhm.
rate below 130 per minute,
Yeah,
respiratory rate less than 25 per minute,
more than 25.
more than 25 per minute.
Yeah,
You need for oxygen,
yeah,
no blanching rash, mottled action, cyanotic,
yeah,
not past the urine in last 18 hours,
yeah,
urine output less than zero point 0.5 milliliter per gallon
yes,
per hour,
yeah.
lactate less than
More
2,
than,
more than 2 millimole,
yeah.
uh, recent chemotherapy.
That's
Yeah.
fantastic. So, if one of these three flags, that the blood pressure has been dropped, the patient is unresponsive, the heart rate is more than 130, respiratory rate is more than 25, the patient still needs oxygen, or there is a new non-blanching rash, or the patient didn't bring in a wee for the last few hours, or the lactate on the VBG is more than 2, or the patient has some chemotherapy in the last 6 weeks and he came in confused, this does mean the patient might have sepsis. If you are taking some boxes there, if you are taking some boxes there, the patient have sepsis. If the patient have sepsis, you will need to make sure that, again, to give him oxygen, to give him fluid, to give him antibiotics.
Mm,
All right?
yeah.
Is that clear?
Yeah.
Good. So if the patient had a sepsis and you take this box, yes, so you should keep the oxygen more than 94%. All right.
Yeah.
Apart from the patient who has type 2 respiratory failure, they need to have their oxygen saturation need to be on the scale 2, which is 88 to 92. Okay. And definitely any patient came in and you suspect sepsis, please do bloods, please do cultures. So you will take some bloods to do the CBC or full blood count, and LFTs, USAs, and CRP, and you'll take blood culture at the same time before starting the antibiotic, and you will take urine culture, and you will take as well sputum culture. Is it clear?
Yeah.
That's fantastic.
Okay.
And after that, so you take the blood, you put the cannula, you put a green cannula in one hand or in two hands if you need to give some bloods later on. You will give antibiotics, and the antibiotics differ from one to another trust. And give the IV fluid. Give the IV fluid. The IV fluid is the most important thing for all the patient with sepsis. How much you should go for? How much? What is the maximum? The maximum is 2 liter.
Mm,
2 liter and 100 mils, which is equal to 30 milli per kg for average weight 70 kg. But you can give more than that. So you will start with 500 mil of normal saline stat, and you can repeat it till the blood pressure more than 90. All right,
yeah.
or till there is a drop in lactate. Okay.
Mm, okay.
You will need to check the serial lactate. So after you started the treatment initially, After 1 hour, you give all the fluid, you give all the antibiotic, and you will check the ABG again to have a look at the lactate. If the lactate is 9, it is critical. If it is dropped after you give 1 liter of fluid, if it is dropped to 6, okay, you need to give more. If it's dropped to 4, you need to give more, right?
Mm.
And contact the consultant and to contact the ITU. Please come and have a look at this patient. This patient, we give him the fluid, we give him the antibiotic, but his lactate is still high. He will need ITU admission. He will need the consultant to have a look at him. All right.
Yeah.
And of course, all the patient came in with sepsis, they are not moving. You will need to have a look and to read and to document the urine output. So everyone come in with sepsis, put in a catheter. You need to
Yeah.
put in a catheter, right? Urinary catheter. Why? To have a look at
Urine output.
urine output. Yeah. Okay. So after you start the treatment, you give the antibiotic, you give the fluid. The antibiotic is, let's say, tazocine, comoxiclab, gentamicin, cefuroxime. If you are dealing with urinary sepsis, then you will give, you will assess the whole situation again. The whole situation every half an hour, every 30 minutes. Assess is the patient news is getting down. Is the patient lactate is getting down on the ABG? Has the X-ray been done? Has the blood results came back to you? Has the ECG has been done? Did you review the patient in a whole again and see he's getting better or still not? If the patient blood pressure is still than 90, you will need to give more fluid. If the patient, his consciousness is still not very well, is not coming back, you will need to reassess the whole situation, give fluid again, fluid to make sure that the patient is okay. If the patient respiratory rate is still high and he's not having enough oxygen, make sure that he's having oxygen, all right? And if the lactate is not coming down, all these problems, you will need to contact the ITU, the intensive care unit, to come and see your patient. Okay, so this is the sepsis protocol. You will need to know the sepsis protocol as you know your name at the moment. Okay,
Okay.
is that clear?
Yeah.
That's fantastic. All right, so let's go to our patient now. So our patient came in, this lady, and we need to put the plan. So this lady, you has been in any and treated for urinary sepsis, and now you came to see the patient and you need to put the plan for her. So the plan will be for this patient to make sure that you have the proper diagnosis. You will write the diagnosis here. Do you want me to write it now, or you're okay with that?
Yeah.
You're okay?
Yeah.
So the plan will be, so make sure that you are treating the acute thing and the ongoing problems as well. So for the acute thing, you will need to put the plan, the investigations that I need to do, that the blood has been taken, the culture has been taken, the X-ray has been done, the ECG has been done, and I have a VBG with me. And if the patient is confused, you will need to run a CT head as well. So this about the investigation, all right?
Yeah.
So the management, the first line of treatment is the fluid, as we mentioned. So make sure that the patient is not a heart failure patient, and make sure that the patient has enough fluid in, all right? So we will prescribe, let's say, if the patient is not having a heart failure and she is not overloaded, you will prescribe fluid over six hourly fluid or 8 hourly fluid accordingly, and to be reviewed again, all right?
Yeah.
And the fluid you are prescribing is maintenance fluid, or if she is still hypotensive a bit, you can give normal saline, all right?
Yeah.
After the fluid prescription, you will need to give the antibiotic. So according to the guidelines or to the protocols that you are having, you will give the antibiotic, which will be cefuroxime for the urinary tract infection, or sometime gentamicin, the first dose, and then you will need to follow up with the to monitor the level of the gentamicin, or tazocin for the patient who has chemotherapy for the last 4 to 6 weeks. All right, and they differ from one place to another place as well. And what about the pain? If the patient has pain, what would you give the patient? Paracetamol is the main treatment. Paracetamol, all right?
Yep.
Don't give ibuprofen for the patient in the hospital, especially if they are having infection or sepsis, because you don't want to have any problem to the kidneys, all
Yep.
right?
Yep.
So after that, you will need to to do reconciliation for her medication. So if she is on any medication, make sure that the medication, if she's having AKI, make sure that you are stopping all the medication causing problem to the kidneys, like the ACE inhibitors, ramipril, metformin, and make sure you are giving the proper dose if there is kidney impairment. All right.
Mm. Yeah.
And for the rest of medication, make sure as well about the diabetes medication, what medication you should put it on, and what medication you should hold. And if you are having any query, if you are unsure about anything, just ask. Just ask the registrars around you. All right.
Yeah.
Okay. Don't
Okay.
make it up. Do not make it up. Just ask, and you will have some answers. All right.
Right.
And we did mention about the frailty score earlier. So the patient will need what we called physiotherapy and occupational therapy. Yeah, is that right? Because she, yeah,
Yeah.
if she's frail, she will
Yeah.
need some occupational therapy and physiotherapy as well. All right.
Right.
That's fantastic. And usually, the registrar or the consultant would expect the date of discharge. He would say 24 or 48 hours, or she will stay in accordingly. Yep,
Yep.
fair enough. All right. So you admitted the patient, you get the patient in. We are talking today about the urinary tract infection. So for the urinary tract infection, there is some basics you need to know. There's some basics you need to know. Today we are discussing about the lower urinary tract and upper urinary tract infection if the patient coming to the hospital. So the CKS guidelines, let's start with the CKS guidelines. If the patient came in with, let's say, this is the one, acute UTI. So this one, the acute UTI, not pregnant and not catheterized, and there's no hematuria.
Can you share screen, please?
Yeah. Can you see it now?
Yeah.
Good. So if the patient came in with UTI, and she went to the GP, and she mentions that she having dysuria or frequency or smelly urine, and the GP depisted the urine, and it did show some leukocytes, and the doctor decided to give her, and I'm talking about the simple urinary tract infection now. So he might give some nitrofurantoin, 100 milligram BD for 3 days if she's a lady, and if she is a man or she is pregnant, he might consider to give it for 7 days. All right.
Nice.
So nitrofurantoin trimethoprim remains the first line, and bivmesilnam remains the second line, phosphomycin as well. But if we are considering admitting the patient to the hospital, we might need to give some IVs first before jumping to the oral thing. All right.
Yeah.
Good. So there is some differences between treatment. I know that I'm jumping from the acute stage to the normal level now. So if the patient in the hospital had urinary tract infection while you are doing the ward round, so you know now that you can give her some nitrofurantoin, all right? And if the patient is, let's say, not hematuria, if the patient is pregnant. If the patient is pregnant, so the antibiotic, whatever you will need to consider cephalexin as the first line, amoxicillin or nitrofurantoin. All right,
Hmm.
but nitrofurantoin you would avoid in the third trimester, and the trimethoprim you would avoid in the first. In the third, and trimethoprim in the first trimester, but for you can give cephalexin or amoxicillin safely 3 times a day for 7 days. All right. So the
Yeah.
pregnant, so the ladies, ladies, we give for 3 days, and for the men and the pregnant ladies, we give for 7 days. All right.
Yeah.
Yeah. Is that clear?
Yeah.
That's fantastic. So this about the one of the most common scenarios in the hospital, how to deal with urinary tract infection in the hospital setting
Hmm.
or urosepsis. We discussed the sepsis protocol today, and I think it became clear to your mind now. And that's all for today. And thank you very much.
Thank you.